Good morning all. Today we'll be discussing lateral sliding flap. Coming on to the history of lateral sliding graph, it was first introduced by Group and Warren in 1956 and they named it as internally sliding flap. And in this full thickness flap was reflected to cover the recession. In 1971, Piper advocated the use of split thickness flap because with full thickness flap there was chances of gingival recession at the donor site. Coming on to the technique, in this incision we'll be starting a V-shaped incision that will be an internal bevel incision. So first of all, an internal bevel incision will be given along the soft tissue margin of the defect. So this is the defect and internal bevel incision will be given. After removal of dissected pocket epithelium, we have to remove the pocket lining. The exposed root surface is thoroughly curated. The exposed root surface, it should be thoroughly curated. A tissue flap to cover the recession is then dissected in the adjacent donor area. So this is the adjacent donor area. The preparation of flap is initiated by vertical incision that is placed parallel to the wound edge of the recession and at a distance that exceeds the width of the recipient bed and the exposed root surface by approximately 3 mm. That means the pedicle flap should have width more than 1.5 times the area of gingival recession. This incision is then extended beyond the apical level of recipient bed and is terminated within the lining mucosa with an oblique relieving incision directed toward the recession site. So the incision is extended beyond the apical level. It should be extended apical to the gingival recession. A split thickness flap is then prepared by sharp dissection within the area delineated by incisions so that the layer of connective tissue is left covering the bone in the donor area. So when we left the split thickness flap, the area it should be covered with connective tissue. An oblique relieving incision is made so far apically that the tissue flap can be placed on the recipient bed without being subjected to tearing force when adjacent soft tissues are moved. So we'll be giving a relieving incision over here so that it can be moved to the donor site, recipient site. The prepared tissue flap is rotated about 45 degree when sutured at the recipient site. The suturing of flap should be done with a 4-0 non-resorbable suture and pressure is applied against the flap for 2 to 3 minutes in order to further secure a good adaptation. To protect the surgical area during the initial phase of healing, a periodontal dressing may be applied. And following removal of the dressing, the suture, which usually takes place 10 to 14 days, the patient is instructed to avoid mechanical tooth cleaning for further 2 weeks, but to use twice daily rinsing with the chlorhexidine solution as a mean of infection control. Indications. This technique is indicated for narrow isolated recession. This is a major limiting factor that it is done in narrow isolated recession only with thick gingival biotypes and where sufficient interdental papilla is there. Advantages: it is well tolerated by patient because it does not involve second surgical donor site and it is less time consuming and excellent post-operative healing result. Contraindication in patient with high aesthetic demand, and it may have the risk of recession from the donor site. There are chances that the donor site might develop recession post-operatively. It is contraindicated in cases of excessive root prominence and in insufficient vestibular depth. Thank you.